Hello, everybody. My name is Austin Orsini, and today we'll be talking about exercise prescription with somebody with a history of atrial fibrillation. What is atrial fibrillation? Some common names of atrial fibrillation are AFib or AF. It is the most common arrhythmia of the heart. Um, it originates in the SA node, which is in the right atrium of the heart, and affects both atrium. So essentially what happens is the SA node in a normal beating heart would send a conduction pathway of electrical impulses from the SA node to the AV node, and the AV node would then send those electrical pathways down to the ventricles in order to cause contraction. In AFib, what happens is there are sporadic, very, very random impulses and conductions sent from the SA node to the AV node, but not all of them are picked up by the AV node, as you will see in a coming slide. There are two types of AFib. There is controlled AFib, which has a ventricular rate of less than 100 beats per minute, and there is uncontrolled ventricular rate, which is greater than 100 beats per minute. There's four classifications of AFib. There's paroxysmal atrial fibrillation, which is start, stop, suddenly, very rapid, very sporadic. And there's persistent AFib, which is sustained for greater than a week, long-standing persistent, which is sustained for greater than a year, and permanent or chronic AFib. So here you'll see normal heart. As I said before, explained, there is the SA node giving electrical conductions throughout the heart from the atria down to the AV node to the ventricles. So on the right here, we'll see a normal EKG reading. We have the P wave that is a summary or showing the depolarization of the atria. Then you have the QRS complex, which is the depolarization and repolarization of the ventricles, and the T wave, which is also repolarization. The rate is 60 to 100 beats per minute. Everything is very normal. Unlike this one, where you'll see on the right-hand side, we have an atrial fibrillation happening to the heart, where you have a ton of different electrical impulses coming out of the SA node, a lot of which aren't picked up by the AV node. And here you'll see down below in the EKG reading how there's a flat baseline for the normal EKG, whereas on an atrial fibrillation EKG, there is a very almost mountainous looking bumpy baseline. So the prevalence of AFib. So it is estimated that 2.7 to 6.1 million people in the United States are living with AFib. And of those people, only about 2% of people less than 65 years old are diagnosed with it, while 9% of people older than 65 years old are diagnosed with it. Both men and women are affected, as you can see in this chart to the left, but as you grow older, it becomes much more prevalent, and we notice that in women that are living longer, women tend to have it more than men do. Some complications that could arise from AFib are the atria depolarizes at a rapid rate, which limits the amount of blood that can actually enter the ventricles to be sent throughout the body, and this is an issue for two reasons. One being you have a decreased cardiac output, which limits the oxygen supply that can go throughout your body. And then the second is that pooling can actually occur in the atria and a thrombi can form. And if this thrombi goes throughout the bloodstream and gets throughout the body, then a clot could occur, and worst situation would be the clot would move to the brain, in which case it would cause a stroke. A few symptoms related to AFib are general fatigue, rapid heartbeat, dizziness, shortness of breath, weakness, chest pain, and fatigue when exercising. These all go back to lack of cardiac output, general fatigue, dizziness, shortness of breath. And aside from those symptoms, when reading an EKG, it's very, very easy to pick it up because you have all of those P waves that are very, very rapid and very irregular. So some risk factors for AFib go into, as we said before, age. Both male and female sex can get it. Diabetes, hypertension, valve disease, myocardial infarctions or heart attacks, and heart failure, also obesity and inactivity. But in at least 60% of these cases, there's two of these factors attributing at one time. Treatments for AFib, there's a few of them. there's medications that can manage the rate and the rhythm of the heart, such as beta blockers or calcium channel antagonists. Beta blockers essentially just stop the sympathetic or suppress the sympathetic nervous system, which therefore lowers the heart rate and blood pressure. You can use blood thinners to manage the risk of clotting or stroke, such as aspirin, or there's also surgical procedures that can be done, such as cardioversion and radiofrequency catheter ablation. And along with those, there are just general lifestyle changes that can be made in order to live a healthier life. Some effects of AFib during exercise. When the exercise level intensifies, a lot of the symptoms could arise, very much so, such as heart palpitations or dizziness and shortness of breath, due to the decreased cardiac output of the atria beating at such a sporadic rate. So the effects of exercise on AFib are you can actually completely reverse the cardiac molding, essentially, and redo, I say redo, the heart's makeup, and to make it a lot more healthy and increase blood flow and increase cardiorespiratory fitness. It's noticed that in short-term exercise, less than 6 months, the burden of atrial fibrillation is actually reduced, and you have reduced symptom severity. And then after about 4 years or so of exercise, you have increased atrial fibrillation freedom. Essentially, you don't really have it anymore. And then the symptom severity is very, very limited. And then the longer you work out, the better. So here we have our case study. We have George, who is a 58-year-old, 5'10", 205-pound male with sporadic episodes of an irregular heartbeat that cause shortness of breath and general fatigue, but doesn't seem to feel any chest pain. After being tested over the course of a year by his physician, the ECG readings clearly show episodes of atrial fibrillation. During his last doctor visit, his blood pressure was measured at 150/82, and his resting heart rate was measured at 86 beats per minute. George was prescribed metoprolol to try to combat his hypertension along with his elevated heart rate. He's also started taking 225 milligrams of aspirin daily to thin his blood in order to prevent clotting during these episodes of AFib. George has no family history of coronary artery disease and is in good standing health otherwise. So there's a few things that we could pick up and take note of here. George's physical condition, he's 58 years old, so he's older. He's 5'10" and 205 pounds, so his BMI is 29.4. The cutoff for obesity is about 30 BMI, so he's almost on the verge of being obese. He's currently on 2 different medications. He's on metoprolol, a beta blocker, therefore his heart rate is going to be lowered and his blood pressure is going to be lowered. And he's also on aspirin. Aspirin itself won't affect blood pressure or heart rate as much, so that's not something to worry about as much making the exercise prescription. His ventricular rate is 86 beats per minute, which is less than 100. Therefore, it's controlled AFib, so we can proceed. And then he has no family history of coronary artery disease, and therefore that is a good sign for him. Some other things to consider, like I said before, George is obese. He's very hypertensive. He's an elevated resting heart rate. He has controlled AFib, as we said before, and he's on the beta blocker. Being on the beta blocker, it's very tough to judge proper heart rate and blood pressure. So 2 ways to approach that would be to not have him take his medication for about 48 hours and have him come in and test him then in an exercise test to get a more accurate reading of his heart rate and blood pressure. Or you can use a rated perceived exertion scale, such as 1 to 10 or 6 to 20, to allow for a more accurate representation of how the patient feels during their exercise, rather than judging based off of their heart rate or blood pressure, which may be affected by the medication. You also have, so for George, I'm going to do a 6-minute walk test. I'm going to assess his blood pressure and heart rate before, during, and after the test. And I'm going to take an ECG of his resting, during, and post-test. being that George just had his blood pressure taken and his heart rate taken in the doctor's office, um, I find it necessary that I'm not going to ask him to stop his medication. So I'm going to ask him to use his rate of perceived exertion scale while doing this, while though assessing his blood pressure and heart rate, just to make sure and have an idea of what those spikes may be during different intensities of exercise. For his resistance training, I'm going to have him do a body weight squat test just to have a general idea of what his strength may be and where I can possibly start him, and at what level of intensity to start him. Some more considerations on exercising with AFib. An increased cardiopulmonary fitness is known to reduce and combat those diseases such as hypertension and diabetes and obesity. So therefore, it's not only trying to reverse the effects of AFib, but also the hypertension and possible obesity that he's on the verge of. He'll most likely have a lowered VO2, and therefore he's going to be able to. Probably going to feel symptoms pretty quickly. The higher intensity he goes, and then we're going to start with a low intensity, low impact exercise, and make the adjustments as necessary, because you don't want him to be showing any symptoms too early or causing any other damage that's not already present. It allows the body to physiologically adapt to the exercise, and therefore it's not going to be just a dramatic spike in his heart rate and blood pressure. So here we have the ACSM guidelines for hypertension. This is just to get an idea of what somebody with just hypertension would do, just as a baseline for where to start, minus his AFib. So we kind of have we're going to do an aerobic exercise for 5 days a week with George. Probably have him do 3 days a week resistance training, and we'll do flexibility 2 or 3 times a week. Start him at a lower intensity for all of these, for the reasons that we said before. And we're going to try to get him to do at least 150 minutes of exercise a week for his aerobic fitness. So for the exercise prescription that I have for George, I'm having him do for cardio. He's going to be doing 5 days a week with an RPE of about 5 out of 10, so about 50% intensity. He's going to be walking for 15 minutes outside, and that's, again, just to start. And then as he progresses, maybe we'll move it up to 20 minutes or 25 minutes, or maybe we'll start doing a light jog. For resistance training, we're going to have him do 3 days a week. He's going to start at 60% of the total number of squats that he did during his test. This is just, again, so that we start at a lower intensity. We're going to do 3 sets of squats, lower extremity accessory work, and upper extremity accessory work. And then we're going to do flexibility 2 days a week. We're going to stretch to the point of tightness for 3 times for 30 seconds each. We could do the V-sit or the prone quad stretch. And then for balance, we'll do 3 days a week to the point of becoming unbalanced. We'll do 2 sets of 45 seconds, single leg stands, and tandem balance. We're going to increase the intensity weekly or as often as he may seem fit without any symptoms. Here's my references. I hope you guys have learned something about exercising with atrial fibrillation today. If you have any questions, drop them below. Thank you.